We're okay. So it looks like we're going to get started. So Dennis can't figure out his camera on his phone, but don't worry, Dennis is here. And if you don't know what he looks like, he's that handsome guy on the side of the screen there. So on behalf of myself and Dr. Dennis Patterson, I'd like to welcome Dr. Michael Song and Jenna Avalo, both here tonight to discuss our spine surgery meeting that we're going to be doing today. And I think that it's really important also, we can go to the next slide, please, Adrian, that we talk a little bit about our agenda. First, Dr. Dorsey unfortunately is caught up in surgery, so Dr. Song and Jenna will probably likely tag team this a little bit, but then we're going to talk about lumbar disc replacements, who is a candidate, and then talking about when we would fuse a patient as opposed to a disc replacement or anything else like that might be in the purview of our neurosurgery colleague, Dr. Song, who's here today. And then Jenna's going to touch a little bit about who is not a surgical candidate and who should be referred to pain management. And then at the end, we'll have a brief Q&A session. And the reality is that you'll be free to ask questions through the chat. So if you have any questions, we'll be monitoring the chat throughout. Next slide, please, Adrian. And I just wanted to say thank you to our sponsor, Sprint PNS. And I'm sorry that my dog just popped in there. So thank you so much, Sprint, for sponsoring this. We are really lucky to have this happening. And the reality is that we're so fortunate to have a dedicated time and educational meetings for our advanced care practitioners that are heavily involved in all of our specialties. And if you aren't currently registered for next week's course, please don't hesitate to join us at PSPS in Las Vegas. And on Friday, we have our APP course. So if you have any questions, please reach out to myself or Dennis or anyone from Mantra, and don't hesitate to email anyone and let us know that you're interested. We'll happily get you involved. That being said, Dr. Dorsey is still stuck in surgery, so I'm going to introduce Dr. Michael Song. Dr. Song is a neurosurgeon who practices in Nevada. I recently learned Carson City is actually not Nevada, it's in New York. Just joking, but I've had the pleasure of meeting Dr. Song and working with him over the course of a weekend. I think he's an exceptionally talented neurosurgeon, and we're very fortunate to have him covering for Dr. Dorsey here today. So Dr. Song, please take it away.
All right, so we were asked to cover a couple of topics, one being lumbar arthroplasty versus lumbar fusion for degenerative disc disease. So this is Dr. Dorsey's talk here, but I'm happy to go through it. So it turns out that the majority of patients that go to surgery for lumbar degenerative disc disease are not candidates for arthroplasty, unfortunately. However, arthroplasty has been around since the 1950s, and it looks like the statistic he shows here is that lumbar disc arthroplasty has steadily increased in its utilization. It's an invasive procedure requiring insertion via anterior retroperitoneal approach. So in other words, it is a anterior lumbar interbody procedure. There are some not FDA approved products that actually go through the psoas, but basically we're talking about an anterior approach. So, you know, Jackie, can you remind me, who is our audience here today?
I'm so sorry I was not quick on the removal of the mute. Our audience is a mixture of both predominantly APP, but also there may be some surgeons on who are also interested with their APP. For the most part, we're targeting our advanced care practitioners.
Oh, okay. So basically, just so everybody knows we're on the same page, to do an artificial disc, you have to go through an ALIF approach. So in general, that involves having a vascular surgeon. Most of us spine surgeons have a vascular surgeon opening up the belly. So it's about a 2 to 3 inch incision just below the umbilicus, usually off to the left side. And it's an approach that goes past the muscles in the midline and then goes directly off to the side through the retroperitoneal fat. Typically, we palpate at that point the quadratus, and we pull over once we feel the psoas muscle and the transverse processes, and then we pull the retroperitoneum and the peritoneal contents medially, and we put in retractors. So, and typically at L5S1, the retractors sit between the 2 iliacs, and then there's another retractor retracting the crotch of the aorta and the iliac veins. So anyway, it's an invasive procedure. So we know about T-lifts, P-lifts, X-lifts, D-lifts, A-lifts. Basically, it's an A-lift approach. But again, the whole point of having this is that the lumbar disc arthroplasty preserves motion and theoretically will decrease the likelihood of adjacent segment degeneration. So the basic idea is if we fuse a joint, that the next joint may have additional forces subjected to it and may undergo earlier degeneration. Next slide. So a lot of these are either metal on metal implants, or it's metal based on some type of plastic implants. So there are two FDA approved products for 2-level in the lumbar spine. The first one was called the Charité, and that was approximately 2004. So I did the first one in Nevada at September 2004. But in the end of the day, Charité, named after a hospital in Europe, that product has been taken off the market because it did not have this controlled and predictable motion. Many of these failed, and many of these went to fusion. So, but the basic idea is there are different axes of rotation and there are different axes of motion. So typically we think about flexion and extension, lateral bending, as it says A, B, and C, and axial rotation. It doesn't mention that there are two other degrees, and that's axial translation. So these can move forward and backwards. But the big idea is to figure out where the instantaneous axis of rotation, if there can be a single spot. So most people feel that the instantaneous axis of rotation is about 1/3 of the way anterior to the spinal column, and that's the main axis at which we have rotation. But the motion, the basic idea is to maintain these various degrees of freedom, and there's 6 degrees of motion that are preserved. Next slide. So typically, this is considered for virgin backs, single level or 2 levels. Typically between L3 to S1, have to be skeletally mature, and typically they have to fail at least 6 months of conservative treatment. So injections, physical therapy, and typically we send them to psychiatry or psychology to have an evaluation to make sure there are no secondary gain issues or any other issues that would decrease the likelihood of a good result. What's not listed here is typically there has to be a poor ODI index or some type of other scale that somebody has to have significant loss of function in order to proceed. Next slide. So exclusion criteria. So talking about more than 2 levels, advanced facet arthropathy. And I understand the audience has everything on mute, but when we're talking about lumbar disc or cervical disc for that matter, what makes it more difficult for us as spine surgeons rather than the orthopods that are doing hip replacements or knee replacements, when you're trying to preserve motion at a knee joint, there's only one joint there. If you're trying to preserve motion at a hip joint, there's only one hip joint there. For us, we deal with 3 different joints essentially. We deal with the disc and the facet. And so we need to see the extent of disc degeneration, but we also need to see if the facets are damaged or arthritic, because it makes no sense for us to replace a lumbar disc if the facets are pain generators as well. So bad bones, osteoporosis, fractures, BMI greater than 40, age less than 18 or greater than 16, rheumatoid arthritis. You know, Jackie, I think the best thing to do would be to just go forward to my slide, because my slide, or my presentation has all these things in it. So we'll just be repeating. Oh, it looks like he's got a case study here. So actually BMI of 38, that's considered a relative contraindication. But the basic idea among spine arthroplasty surgeons is that we, in general, especially when we're first starting out, we want to limit the criteria. So we want to follow strict FDA criteria because we want to make sure that this procedure has reproducible good results. So this I'm sure this guy did well, otherwise he wouldn't be presenting it, but technically BMI greater than 38 is a relative contraindication. So we can see here there's one level, L5S1, that's much more markedly diminished than the other levels. This guy has a fair amount of stool as well. Anyway, next slide. So we see modic changes on the sagittal T2 weighted MRI. So theoretically, Intracept could be a procedure considered for this. The axial view shows a little bit of lateral recess stenosis. There's also what appears to be a foraminal disc on the parasagittal images. So next slide. Okay, so lots of different options. Again, another option not discussed is Intracept, but all of these are actually good options. And in fact, we would consider epidurals, facet injections. One thing that we have to make sure whether we're doing a fusion or arthroplasty is we know for darn sure what the pain generator is, because if we're not 100% sure, or at least 99% convinced as to whether the disc is the pain generator, we really shouldn't be doing this procedure. So oftentimes if we have more than one pain generator, we can either go at it one at a time with the facets or just consider a stimulator because we don't burn any bridges that way. Also with modic changes, we can try Intracept. But anyway, next slide. Okay, so it looks like this person or Dr. Dorsey chose a L5S1 Pro disc. So anyway, patient did great here. So something that we can discuss a little bit later, it's considered a relative contraindication if somebody's lost more than 50% of disc height. However, many of us that do lumbar disc arthroplasty, we tell patients that and say, listen, we're going a little bit beyond the strict criteria, but I think you'll do great. We can discuss this later, but the basic idea is if the disc is diminished more than 50%, that the facets probably have some contribution to the pain pattern. And if we open up a disc space twice as high without dealing with the facets, that we can create pain generators. But anyway, in the right hands with the right judgment, this patient could do well. And apparently this guy's lost 70 pounds. So too bad for his Weight Watchers description. Next slide. Okay, great. Next slide. Okay, so that's me. Next slide. So the basic, we were thinking surgery for lumbar degenerative disc disease. As we can see in the teal color, I'm not sure how it looks on your computer, but essentially 1 out of 6 patients are going to be candidates based upon inclusion criteria. So basically, more than 85% of patients that have degenerative disc disease that go on to have a surgery, they're more likely to be candidates for fusion. So in general, we think of these in terms of 2 broad categories. We think if there are any sort of patient contraindications or any instability issues. So if there's a pars defect or spondylolisthesis, having a herniated disc with radiculopathy, really collapsed disc height, or severe stenosis. Some people include even having a microdiscectomy in the past as being a contraindication. But basically on the ProDisc scale IDE study, only 1 out of 6 patients were candidates. So the minority of patients are candidates. So a lot of this was covered in the prior talk. However, when we're discussing or thinking about arthroplasty versus fusion, if there's a problem with the bone, if there's too much osteoporosis or osteopenia, that's a contraindication for obvious reasons, but we'll just get into it. If the bone is too soft to support the implant, we're talking about revising the implant or getting subsidence, and then that's going to lead to either some type of revision. Once we go in through the front, it's very hard to go back to remove the implant. So oftentimes those patients become fusion candidates from the back. If there's a structural or degenerative scoliosis, they're not a great patient for arthroplasty because the whole notion of having an artificial disc is to maintain normal motion. And if there is loss of disc height greater on one side than another side, putting in an implant where the forces will create a loss of height on one side favorable to the other, that's just not a good solution. Another thing to ask, is there a loss of lordotic angle in the segment of the spine as a whole, or is there too much kyphosis? Is there central canal stenosis or foraminal stenosis? So in general, if we're doing arthroplasty, we're doing it for strictly low back pain, axial low back pain, not for radiculopathy. Pars defect, that's a contraindication given the instability. Anterolisthesis, retrolisthesis, lateralisthesis, sorry, there's a typo. Somebody just told me that she's very keen on typos, so sorry about that. We always have to ask ourselves, how unstable is the segment and how much height has the disc lost compared to a healthy adjacent disc? Next slide.
Dr. Song, before you go on, we have a question from one of our attendees who would like to know, first of all, thank you for noting the typo. I appreciate that. But the question is that, are there any roles for discograms in disc arthroplasty, and how many patients these days are you sending for discograms, and when?
Okay, I think that's a wonderful question. I think there are a number of well-written articles in supported discography, and there are a number of articles written against discography. So to answer that question succinctly, discography is highly controversial. If I have a good guy in my community, like Dr. Patterson, fortunately, I got Dr. Patterson in my neck of the woods. I know how he's going to do it. So in general, when we can, as surgeons, when we consider discography, we typically are trying to consider whether we need to do more than one level, or whether we can exclude that patient as a surgical candidate in the first place. So for example, 5-level positive discogram is not something that we would do surgery on. If we have a collapsed disc like we had seen in Dr. Dorsey's case study, then L5S1 is definitely symptomatic, most likely, at least it appears so. Let's say L4-5 is slightly loss of disc height, or let's say it has some modic changes, or a patient has an annular tear in L5 radiculopathy, then a discogram in that case could give us a sense whether that level should be included. The other thing is we like strict ISASS criteria followed. So considering that the patients are put under propofol, the contention is that just if you stick a needle in the disc, that can be painful. So we want to eliminate that. So the patient's under propofol, they're woken up once the needles are in, and then injection is done. We're looking for any abnormalities in the injections. We want to see what the pressures are in the injections, and want to see if there are any annular tears in which the injections come out. In which the contrast leaks. And then we want to ask the patients, does this reproduce your pain? And how bad is the pain? Is this pain bad enough? Is this a type of thing that you would want to have surgery to cure? So that's a positive p-value. Typically, we tend to do R values as well. So we usually ask our discographers to also inject a local anesthetic. So by injecting a local anesthetic, if that anesthetizes or removes the pain, that's a positive R value. So the other thing that we have to have is a negative control. So in my experience, if we have a really good discographer and we're following ISASS criteria, then I feel that discography can be a very useful tool. There are drawbacks also. There are some people that say just sticking a needle in the disc is enough to cause it to start or accelerate the degenerative cascade. So anyway, it's highly controversial. However, in my personal experience, when the right criteria are followed, propofol, positive P2 value, positive R2 value, with relief of the pain with injection, positive control, meaning a negative control. And we usually send the patients to CAT scan afterwards. But anyway, that can be very, very helpful. But that being said, I probably order less than 10 a year. And I see probably 1,000 new patients a year. So I probably don't order too many, but it can be very useful. Also, we ask ourselves, are modic changes present? So I consider that also because of the new procedure Intercept, because sometimes those patients may be candidates for that by doing a radiofrequency ablation of the basivertebral nerve. But anyway, we ask ourselves, are the facet joints normal? Are there osteophytes? Where are they? At what point is this disc in the degenerative cascade? In other words, is the degeneration too far gone? This question about calcification of the abdominal vessels, that's important because the last thing we want is to talk to the family afterwards and say, hey, I got good news and bad news. Good news is the x-rays look great. Bad news is we threw a clot, this calcified clot off the aorta, and he's just going in for a limb amputation. So anyway, but the x-rays look great on the back. So anyway, that's important to ask because you need to consider the approach. We're coming from the front. How do observations equate with symptoms and signs? Are there further absolute or relative contraindications? So those are typically 18 questions that most surgeons will consider while they're trying to place their patient into the artificial disc category or the fusion category. Next slide. So, the IDE study and the FDA study for this put very specific inclusion criteria for the ProDisc. So I think we're a little bit running out of time, so we'll just do a couple more slides here. So basically, degenerative disc disease between L3 and S1. So in other words, we're not doing an artificial disc at L1-2, and we're not doing one at L2-3. So typically, we want to see any more than, or we don't want to see any more than 3 millimeters of translation. Most insurance companies look for 5 millimeters of translation at L5-S1. L3 to L5, they look for 3 millimeters or 5 degrees of angulation with flexion and extension dynamic imaging. Decreased disc height less than 2 millimeters. That case study that Dr. Dorsey showed, that disc height was lost like 7 to 8 millimeters. However, like I said, if you get the right surgeon and the right patient with the right assessment to see if opening up that disc space would jack open the facets, you could still have a very successful patient. And some of the studies in some of my last slides, the very famous professors have talked about how they've had very good success. However, most people are recommending sticking by the strict inclusion criteria. So if your disc height is lost 50%, strictly speaking, you are not a candidate for arthroplasty. If there's scarring or thickening of the annulus fibrosus, that goes to prior surgery. Herniated disc, vacuum phenomenon, all those are considered sort of contraindications. Age between 18 to 60, basically you can't put it in a kid, and you don't want to put it in somebody that's a bit older that may have some osteoporosis. Most of us view this as a physiologic age. So if somebody's 70 and they look like they're 50 and their bone density shows they look like they're 50, they may still be a candidate theoretically. Need to fail at least 6 months of conservative treatment and need to have a 40% on the ODI score, and we need to have some type of site clearance and obviously informed consent. Next slide. So just as we discussed that the minority of patients can actually be eligible for arthroplasty, you can imagine that the exclusion criteria slides are much longer than the inclusion criteria. So no more than a single level may have degenerative disc disease. So that's not actually true anymore. So we actually have 2 levels between L3 and S1 that can be FDA approved with the ProDisc L. However, when this slide, when this slide was made, I think this was 2015, 2 levels were yet to be approved. Patients with involved vertebral end plates, dimensionally smaller than 34.5 millimeters in the medial lateral or 27 millimeters in the AP direction. If you're smaller than that, you're not a candidate for this disc because it has to be at least that size just to get it in. Any allergies to the materials, that's obviously a no-no. Prior fusion surgery at any vertebral level, strictly speaking, that's an exclusion criteria. However, when we first started doing Charité in 2004, if patients had 2 levels, we would do an ALIF or fusion at L5-S1 and arthroplasty at 4-5. But hybrid procedures, strictly speaking, are not FDA approved. So doing single level fusion and arthroplasty at the adjacent level, that's called a hybrid. Anyway, it's considered a no-no, but many of us do it all the time. clinically compromised vertebral bodies at the affected level due to current or past trauma. Also, if somebody has a congenital condition like hemivertebrae. Again, this points to when we were talking about degenerative scoliosis, if the disc height is abnormal on one side compared to the other, or if the vertebral body height is different on one side compared to the other, that can affect abnormal loading onto this disc. Degenerative spondylolisthesis of grade greater than 1. So all of you know there are 4 grades of spondylolisthesis, and typically it's graded in terms of 25% or quarters. So grade 1 is less than a 25% slip. Grade 2 is less than a 50% slip. Grade 3 is a less than 75% slip. Grade 4 is less than 100% slip. And beyond that, that's called spondyloptosis, or grade 5. So anything more than a 1, even a 0.5, most of us don't want to touch that with an artificial disc. Back or leg pain of unknown etiology, let's say negative EMG, doesn't follow a dermatomal pattern. Anyway, osteopenia or osteoporosis. So typically -1 is the cutoff. Paget's disease, osteomalacia, morbid obesity, BMI greater than 40, pregnant or getting pregnant in the next 3 years. Infection, obviously that's a bad no-no. Steroids or any other medications, rheumatoid arthritis or autoimmune disease, systemic disease, active malignancy. Next slide. And indications and contraindications for ProDisc L is basically what we talked about. So 6 months, non-surgical treatment, skeletally mature, single level between L3 and S1. And contraindications, basically everything that we talked about. Next slide. So these very famous professor, Bertagnolli, so I think I'm going to see him in October, going to Italy for Eurospine, and then Germany to see Dr. Bertagnolli. But they wrote a paper stratifying indications for TDR into 4 categories. So in Europe, they can do all sorts of crazy stuff. Anyway, remaining disc height, status of the facet joints, adjacent level degeneration, and stability of the posterior elements. So remember, the things that we're talking about are strictly related to FDA clearance in the US. I actually have a patient that we sent to Dr. Bertagnolli. I was going to do a spinous process device many years ago, but he ended up with a 12-inch incision in the front of the belly, had 3 levels of ProDisc, L3-4, L4-5, L5-S1. And because he had a slip at L4-5, Dr. Bertagnolli put in screws and then a dynamic stabilizer. So rather than a metal rod, put in a plastic rod. So that is completely off the ranch. However, that patient after a year did exceedingly well and probably will never need back surgery again. So Chin and Wang discuss contraindications into 2 broad categories. If there's a painful condition not caused by the disc. So, you know, even as surgeons, or especially as surgeons, we really have to figure out what the pain generator is. And that's where so much of our interaction intersects with our pain management colleagues, because they can help us interrogate the posterior column. We can consider discography. We can do EMGs and so forth. But anyway, conditions that may compromise long-term device function. So that goes to the autoimmune diseases, steroids, osteoporosis. So anyway, when do we fuse degenerative disc disease? If the patient is not a candidate for artificial disc, they fail conservative treatment, and we know that the degenerative disc is the only pain generator. Next slide. So that's my bibliography. So anyway, happy to take questions or do whatever I can to help.
Thank you so much, Dr. Song. Now it is my pleasure to introduce Jenna. Am I pronouncing your last name wrong or right? Abelo, is that correct?
Abelo.
Okay, great. So Jenna is actually an acute care nurse practitioner who works with Dr. Michael Dorsey down in the Los Angeles area as part of the UCLA community neurosurgery offices. Unfortunately, Dr. Dorsey was not here, but Jenna was able to join us and follow Dr. Song. So Jenna is going to talk about when patients are not a surgical candidate and should be referred to our interventional pain colleagues. So Jenna, take it away. Thank you so much, Dr. Song. If
Yeah,
you can
thank you.
hang out for a little bit and so we can have our panel at the end, just feel free to turn your camera off so you
Oh,
can
okay.
relax.
Thank you.
All right, Jenna, thank you. Take it away.
Hi, everyone. Thank you for having me. So I will be presenting the topic of who is not a surgical candidate and who should see interventional pain. I thought that this would be a really good topic for me to present because this is one of the core reasons for why I have a job as a nurse practitioner in a neurosurgery practice. So in order to kind of get the wheels turning, I thought it would be a good idea to do kind of a mini quiz of sorts and take a look at some imaging and just to kind of gauge where you guys are at in determining who would need surgery versus not. And so this first case here, this is a picture of the lumbar spine, and it shows mild to moderate degenerative changes in the lower lumbar spine, particularly at L4-5 and more so at L5S1. There's also some facet arthropathy, ligamentum flavum hypertrophy, and overall pretty well preserved lordosis. So that's the first of two recent cases that I've seen. And then moving on to a second case that I saw just a few weeks ago, this patient has some significant rotary scoliosis and rather significant multi-level lumbar spondylosis and discogenic disease, particularly in the mid to lower lumbar spine. There may even be a little bit of arachnoiditis if we look at axial imaging on the right, where the nerve roots look a bit clumped. So long story short, there's a lot going on. So you guys are welcome to say what you think in the chat or just take a moment to think to your answer to yourself. And I will move forward. Let's see. Looks like I'm frozen here. Sorry. Are you guys able to get the next slide going forward? There we go. So pretty much that was a trick question because the answer is we cannot determine who requires surgery versus who does not based on imaging findings alone. Now, logically, this is something that we as providers know. We very rarely ever make a decision based on only one piece of data. But I'm mentioning this because the trend is that there's a knee-jerk reaction to refer to neurosurgery for people who have lumbar spine MRIs, especially if their imaging shows multi-level or severe degenerative changes. There seems to be more of an inclination to refer. And so in order to guide your decision-making process in terms of how to triage your low back pain patient or lumbar disc degeneration patient, I suggest asking yourself 3 key questions. And those are how does the patient function? How does the patient feel? And does the clinical picture make sense? So I ask myself these every time I see any patient, really. And it's really, these questions are really rooted in the very basics of practice. So the first question, how does the patient function? That's really in reference to the neurologic exam. Now, it's not very practical to cover every single one of these bullet points for a chief complaint of low back pain, especially if there aren't any other major risk factors that would suggest a central nervous system etiology. But I do want to give this slide to you for reference because I think it is really important to be well versed in doing a comprehensive neuro exam. And for every patient that comes in, I think it's very important to do a comprehensive motor, sensory, and reflex coordination and gait exam. Even if they come in with low back pain, I think it would be important to also assess the upper extremities because surprisingly, in my practice, I've been able to find lots of other problems that the patient didn't initially clearly present with by doing that. For example, it's pretty easy to skimp on the motor exam, and this is something that I've unfortunately seen over the last 6 years that I've been in neurosurgery. Most recently, there is a 42-year-old patient who came in with a chief complaint of back pain. She was an IV drug user. Ultimately, she was discharged from the ER and came back 2 days later in full-blown thoracic myelopathy due to an epidural abscess. Upon review of her case, she did present with symptoms of early thoracic myelopathy, but the exam doesn't seem as though it had been as comprehensive as it needed to be. And now, even with surgery, she's unfortunately paralyzed from the waist down and can only wiggle her toes because of that miss. So that's just kind of really drilling in the suggestion to do a comprehensive exam. And then if the neuro exam is not something that you're very comfortable with, this website, neuroexam.com, has been very helpful for me in my practice. And it accompanies Dr. Hal Blumenfeld's textbook, Neuroanatomy of Clinical Cases. I suggest you check it out if you need some refreshing skills for your clinical exam. They include short videos with explanations, so it's very helpful. And then moving on to the next question of how does the patient feel? We all know in our patient population that this can be a very loaded question, but it is very important to understand the extent of the chief complaint, the patient's treatment history, and the response to the past treatments that were done, as well as relevant past medical history and social history and psychosocial status. And once we gather all of that information, we want to ask ourselves, does the clinical picture make sense? It's really easy to get carried away when you're presented with a MRI finding that has a severe finding listed on the radiology report. But there's been quite a few times where a patient comes in with severe lumbar stenosis, recent onset bilateral lower extremity numbness and paresthesias, had been told they need surgery, but really the source of those paresthesias could be either peripheral neuropathy or cervical myelopathy upon further evaluation. So that's just something to keep in mind. And so when we consider the main point of this talk, which is who should see interventional pain management and is not a surgical candidate, it's actually easier to list who the ideal candidate for a spine surgery referral is, because overall that list on an outpatient basis is pretty short. The diagnoses that I have in bold are actually situations that are more commonly seen in an emergency room situation or an inpatient situation. At times they do arise in the outpatient clinic, but for the most part, outpatient, we would deal with pain refractory to non-operative care, and then also new neurologic deficit or neurologic deficit in general, depending on the situation. And on the topic of timing, I just wanted to mention that mostly in regards to neurologic deficit, I do feel that it's appropriate for referrals to be placed if there is an acute neurologic deficit, such as a foot drop or weakness, neurologic weakness. It would be really important to establish neurosurgical care in that situation, because in general, the sooner that surgical intervention can be done, if indicated, the better the outcome tends to be. And there's quite a lot of contention when it comes to timing of surgery in general. Most of the literature seems to be geared towards lumbar radiculopathy due to disc herniation. And there's a general consensus that surgical intervention for radicular deficit within 6 months tends to produce the best outcomes. As far as symptomatic lumbar stenosis with neurogenic claudication and axial low back pain, these diagnoses are a lot more controversial in terms of the ideal timing for surgical intervention. And if there isn't a significant motor or sensory deficit, generally we do have a little bit more time to decide on treatment. And then cauda equina is not something that we typically see in the outpatient basis, but if you have suspicion, that would be something to always refer a patient to the emergency room for. And so I just wanted to touch on consequences of inappropriate referral, and this pertains to both referral to neurosurgery and referral to interventional pain management. Inappropriate referrals cause longer than necessary wait times for treatment, and this delays the relief of symptoms for patients who both need and do not need surgery. These inappropriate referrals can also cause a great waste of patient and provider time and resources. And patients get genuinely very stressed out when somebody gives them their MRI report, tells them they're a mess, you need surgery right away. And that type of expectation from the patient can cause significant distress. Also, there's data that referrals to surgeries lead to more surgeries. So one of the study listed here did a survey of US spine surgeons, and it found that depending on the surgeon's region and academic affiliation, there was actually a great difference in who recommended surgery versus who did not. For example, the surgeons that were affiliated with an academic facility were 4 times less likely to recommend surgery versus those that were in private practice. So this is just something to be mindful of, that the level of aggressiveness, so to speak, of the surgeon does differ throughout the community. So it would be important to establish relationships with your neurosurgery colleagues in order to help guide the patients towards the best treatment plan. And so to wrap things up, I just kind of wanted to remind you all to beware of the imaging results trap. It can be really intimidating to receive a report that has 2 pages wrong with the patient listing the words severe, 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 severe. But at the end of the day, it really requires you to go back to the basics of the history and physical in order to best triage your patient in terms of determining should they see surgery or should they see interventional pain management, or should they start even smaller and do non-invasive conservative care measures. And so if anybody wants to delve into my resources further, here they are. And thank you for letting me present. If you guys have any questions, I'd be happy to answer.
Thank you so much, Jenna. And you know, what was really, I think, important that you touched on in that last few minutes there was, you know, not to treat just an image. Dennis, yeah, great. Not to just treat the image. And Dr. Song, if you're still there, great. Because I think, you know, particularly in this day and age with my chart and patients' access to their imaging reports right away, I think, you know, the average person who doesn't really have good medical knowledge is going to read that report and they say severe and multiple and and then they come in and they're clutching this like MRI report like, oh my God, I'm gonna die, it says it's severe. So I think, you know, that correlation with the physical exam is so important. Michael, can I ask you a question? So when you get a referral to your office and let's say like, you know, the patient has done absolutely nothing. I know in my community, no matter how long I've been here, patients still get referred to the spine surgeon right away. If, you know, oh, we got an MRI, they have pain, we're sending them to the surgeon, they haven't done, you know, any conservative care or anything. Are you simultaneously referring your patients, assuming that they don't have a surgical emergency, are you simultaneously referring your patients for conservative treatment like physical therapy and pain management at the same time? Or what's your kind of algorithm when you're seeing these patients come to you that have done nothing and are not necessarily a surgical emergency?
That's a great question. So first of all, thank you, Dennis and Jackie, for inviting me to this. And then thank you, Lakin, as well. And Jen, I learned a lot actually from your talk. So I think you had a very nice way of voicing a lot of surgeons' frustrations about things, because we spend a lot of time telling patients you actually don't need surgery, or that patient with a bad scoliosis may actually have an SI joint, or, you know,
Right.
I saw somebody, I don't think you can see here, maybe my camera can show it, but somebody was referred to me today for severe stenosis, and I don't think it will show up here on the picture.
Oh my gosh.
Okay, well, so I don't think you could see, but it had severe stenosis, truly. I'm sorry, that's not showing up well, and it's got the left-right dyslexia, but he has a left avascular necrosis of the hip. So you can see that femoral head's, I don't know, it's like a piece of popcorn. Anyway, had a huge L2-3 disc, had severe stenosis L3-4, had L4-5. I know his recovery from hip surgery is going to be longer than back surgery. However, this guy just had classic hip symptomatology. So this guy actually did have severe stenosis, even had the groin and anterior thigh, but it was actually more from his avascular necrosis. So that's just somebody I sent today. So truly, at the end of the day, if we want our good results, we really got to know, what the pain generator is. But my practice is a little bit different, and I really need to change my practice because I have a hard time saying no. So somebody with a negative MRI, typically we'll still see them, especially now that, that I've had more interaction with my pain colleagues like yourself and Dennis, where I think that, well, gosh, you know what, this patient may be a stim candidate. This patient may be a candidate for Intracept. This patient may be a SI joint type of thing. But typically, it sounds like, Jenna, you're in academics. So I think in some ways, I don't want to say relationships matter less, but for us, the lifeblood of our practices, me and Dennis, Jackie included, is just relationships. So I may have operated on somebody's cousin. I look at the films, and you're right. Sometimes you can't look at the films and know what surgery they need, but oftentimes you look at the films and they don't need surgery.
Right.
So the opposite of that may be true, but anyway, we typically still see them, just because we think that, I don't know, every patient has 30 some bones in their back, and if
Which
nothing
makes
else,
sense. It does make sense. I'm not saying that these
but it
patients
bogs
should
me
never be
down.
seen,
It
but
makes me frustrated. It makes me cranky. But anyway, I 100% agree with everything that you wrote. But typically, yes, then we get along with our interventional pain colleagues, try to come up with a treatment plan. And when we have good colleagues, like I got a good relationship with Dennis, I know they're coming back to me. I send a patient to Dennis. He can do everything he can. And I'm not losing sleep thinking he's going to send him to my competitor. So, we really build these relationships with our pain guys. And at least in Northern Nevada, we still have tremendous ability to have good, private practices. But at some point, we may need to join forces and have a multidisciplinary type of setup. But at this point, we have no problem triaging, especially with work comp or lean cases. So, and oftentimes those images are pretty darn negative anyway. However, we then gain the control as to where the patients go, develop that referral type of collateral, continue to build on the relationships. And, we have the ability, especially for work comp, our goal with work comp is try to create a more functional society. So if somebody has a lumbar strain, we don't want that case going on for 3 years.
right.
We want to shut down in 3 to 6 months, and we don't want somebody, poor patient getting a 5-level fusion and then patient being disabled and all this other stuff. So anyway,
I mean, we're not mad at that because then they end up getting a spinal cord stimulator.
But anyway, we do it still, but I need to change. I need to be better like you and just
maybe what you need is a nurse practitioner, because my function is to pretty much triage the patients. In Dr. Dorsey's spine practice, I see new consults and whatnot, and then we do have actually quite a good rapport with several pain management groups local to us.
Oh, I'm sure you do.
So,
I didn't mean to discount relationships.
Yeah, so maybe you need a nurse practitioner who can do the triaging for you.
Well, you got a twin sister.
Let me throw something out there. So, being pain management, and I'm sure Jackie's heard this too, is, kind of our training is bowel and bladder incontinence, instability, or progressive neurologic loss. That's a, instant surgical referral, but referring for pain, unless it's a clear surgical lesion, isn't as obvious. And so, kind of what I hear surgeons sometimes talking about pain management is that we hold on to the patients for too long, that we should send them for our surgical consults more readily. or sooner in the algorithm. And I guess, you know, how do you guys kind of help us, you know, kind of know where that line in the sand is? Because I think it's very difficult sometimes. I mean, we've seen some patients, you know, I've even seen some patients now in my clinic for 13, 14 years now. And, you know, I've never sent them for a surgical consult, but, you know, there's never been clear indications. And I guess, should that have been a person I sent a long time ago just to have you guys say they're not a surgical consult so they know that what we're doing is right? Or I guess, what's your guys' opinion or thoughts on that? Because there is that reputation that pain management holds on to the patients too long.
I think maybe that reputation, oh, sorry, go ahead, Dr. Song.
Oh, I was just going to say, unfortunately, the cards are stacked against you because surgeons are never happy. If our clinic's full, we're like, oh my God, I'm too busy. Or if there are several can't say, oh my God, what happened? Am I losing my touch? And then if we get one from pain management, we'll think, oh, these guys, they never refer anything, and look at it like, oh, they just want us to say it's okay to do a spinal cord stim. So, but, you know, to try to answer your question, not in jest, but honestly, I think if there's severe stenosis, I think if there's a slip, I think if patients on their, I don't know, 5th epidural or something, but, you know, I mean, I trust your judgment, Dennis, but it is true. We see lots of patients that have had pain management and said, you know, we thought we had surgery.
I mean, on that note, because we're running short on time, and I think the question probably is a very valid question, Dennis. I think we probably, like you said, tend to hold these patients on a little longer. But I think we're also trying to be judicious about like dumping everyone on surgery just because of exactly what Jenna talked about, like their physical exam. But I think, you know, it's a really great coordination of, you know, patients failing conservative care. Now, briefly, we had one of our members ask, can one of you comment on allograft or cadaveric disc as opposed to a disc arthroplasty? So what's going on in the space regarding that?
The question is bone graft material using... It
says, yeah, allograft or cadaveric disc as opposed to disc arthroplasty. So I think maybe some of the injectable stuff or like Viadisc, and I don't want to use, you know, all the brands, but basically injectable disc protein, things like that we're using as opposed to a disc replacement itself. What are you guys seeing? And if you don't have a lot of that happening by you, Michael, maybe Jenna, you're seeing more in the LA area, or what are you seeing with any of that?
Yeah, so some background, Mike, on the pain management side for the disc degenerative disease, we talked about BVN ablations, you know, Intercept, and we talked about allograft, you know, this Viadisc procedure last session. And so I think that's what they're asking now is, you know, saw that, now we see that there's a disc replacement. Where should things fall in line here?
Well, I'll speak briefly. One, we really don't deal much with that. Two, I do think that some non-FDA things, you know, are very interesting. Potentially stem cell injections in the right patient, and again, we need to ask ourselves, where are they on the degenerative cascade? But again, typically, we're not even talking about surgery. I mean, I know I was supposed to talk about when do we do surgery for lumbar degenerative disc, but typically there's a lot of pain and a lot of pain management that occurs before we even see the patient. So, but in my practice, we have very little stuff, but you know, we are offering stem cell injections into the disc. So I don't know what you're doing down there, Jenna.
Yeah, Jenna, you have a lot of people down in Southern California that are into that stuff. Anything, I don't mean to say stuff is like a bad thing, but I mean, obviously like Tim Davis is down there. You know, David Lee, a lot of our colleagues are down there. So what are you seeing in the community, and what are yours and Dr. Dorsey's thoughts on that?
So truly, we actually don't see a lot of that in the community, and it's not often something that Dr. Dorsey recommends as a treatment alternative to a disc arthroplasty. I think mostly because the data isn't as solid as it is. Yeah, is robust. Perfect word. Yes, in order to support recommending that. So we actually don't see a whole lot of that in the community where we are, which is actually north of LA. I'm sure in the LA area, there's probably a lot more of it.
Well, I mean, in my mind, everything in Southern California is basically
Is
LA
LA.
or not LA. I mean, sorry, I think that generalization. Well, on that note, thank you both of you for taking time out of your busy day to join Dennis and I. I think, you know, we've been really trying to curate these series, and as a lead up to our APP course at PSPS next week, again, thank our sponsor Sprint. Peripheral nerve systems for this. And if, again, you haven't registered next week, please don't hesitate. We have tons of room left at the conference, although rooms may be getting pricey because it is a very busy week in Vegas, but we'd be happy to see you. And if you have any questions, please don't hesitate to reach out to any of us on the panel. I know Dennis and I are very easily accessible and can pass your questions on to Jenna or Dr. Song. And thank you all. Dennis, do you have anything else you want to add?
No, just please come next week to the conference. You know, besides the APP course, we've got the regular conference that's going to take place on Saturday and Sunday. It's going to be a good collaboration between psychology, pain management, and spine surgery. And on top of that, we also have a lab the day before. I don't know if that's sold out yet, but a lot of
the lab is sold out. It is sold out. But I mean, I was going to just say one more thing. And if you are an advanced practice provider who would like to get involved with the APP course or any of these talks, and you have an idea about something that you'd like to do, please, please, please don't hesitate to reach out to Dennis and I. We're always looking to include more of our community. And the reality is that, you know, we don't want to always have the same people. We want to keep it fresh and new. And so please don't hesitate to reach out to us. Thank you so much. And again, thank you, Dr. Song, and thank you, Jenna, for your time this evening.
Yeah,
Thanks.
thank you guys.
Thank you guys. Have a wonderful night.
Thank you.
Thank you.
Thanks, everybody.